So, Assalamu alaikum and good evening, everyone. Welcome to the series of acute coronary syndrome educational activities. As you all know, these educational activities is happening every quarter. And what we're trying to do is to address the different aspects of management of acute coronary syndrome, from diagnosis to treatment and management. Every part of this series, we try to focus on an aspect of the care of acute coronary syndrome. And tonight, the focus is going to be on the diagnosis and specifically on the role of biomarkers, troponin mainly. Tonight, we have a busy program. We got 5 talks that's going to be detail and address all the aspects of hopefully the aspects of biomarkers. I am honored to have an excellent panel with me, and I would like to thank them on behalf of the Emirate Cardiac Society for their valuable time and being present here with me. They will go over, as I said, all the different aspects that hopefully will be of a value to you. We have Professor Evangelos Jan. This is from University Heidelberg in Germany. He's a professor of medicine, and he is a well-known international expert in biomarkers and in troponin. We have Dr. Leila Abdulwarith, the chair of pathology and lab at the Cleveland Clinic Abu Dhabi, and deputy CEO and chief scientific officer at the National Reference Lab. We have Dr. Aisha Ma'mari, board certified emergency physician and critical care physician. She's a consultant and with a lot of experience in developing policy and protocols in the area of emergency medicine. We have Dr. Salama Al-Hosani, family physician from the primary healthcare department or in Abu Dhabi. Also, we have Dr. Rabi' Azar, professor of medicine at St. Joseph University and the chief of cardiology, also from Lebanon. So, you know, an excellent panel and a lot of things to address tonight. A few gatekeeping or housekeeping stuff that we want to make sure that you are, you're aware about. This activity is a CME accredited activity, and so you please fill the evaluation at the end, and our colleagues from the organizing company, ICOM, will get you your accreditation points. Another important thing is such session is of a value when there's an interaction. So yeah, I know we have a lot of dedicated lectures, but we're trying to keep a lot of time at the end for discussion. And without your interaction, without putting questions, without listening and raising, questions, we will not be able to pass, the message that we want. So please feel free to post your question and preferably in the Q&A. Also, we have the chat box, but I prefer that we keep all the questions in the Q&A, and I hope that's straightforward, easy, to find in your screen. So those are the points I think we need to highlight. Also, I would like to thank our colleagues from Roche for their support for this symposium, and our colleagues from ICOM for the organization and following up with all of the panel and myself to get things done. So without a lot of delay, I think we'll start with Dr. Evangelos. So Dr. Evangelos, as I said, is a professor of medicine an international expert in troponin, you know, he got us a high sensitivity troponin rule out, the best protocol. So we're going to hear the best protocol for a rule out. Dr. Evangelist, go ahead.
Yes, dear Chair, ladies and gentlemen, it's a great pleasure to be part of this excellent session that is digital, unfortunately not live. As mentioned, my topic is best protocols using high sensitivity troponins. I have some disclosures. So what is relatively new is the last year's ESC guidelines on the management of ACS, and most of my recommendations can be read here, and I will refer almost exclusively to these guidelines. What is new in these guidelines? Still, high sensitive troponins are highly recommended. If available, they should be used, and the results should be available within 60 minutes. So there's a demand on the infrastructure to be able to deliver results within 60 minutes. Then a 1B recommendation is to use the 0 and 1 hour algorithm that has been validated, and 1B is a very strong recommendation. And if this protocol does not provide a consistent categorization of the patient into rule in or rule out, then a third measurement is recommended at 3 hours, because at 3 hours, there is only the decision to rule out or to rule in. What is an alternative to the 0 and 1 hour algorithm is the ESC 0 and 2 hour algorithm. That's a little bit surprising, because until these guidelines, few people know about this ESC 0 and 2 hour algorithm. Before, ESC 01 and 03 were almost equivalent and were recommended as alternatives. And what is now the case is that the 0 and 1 hour protocol has been regarded superior to the 0 and 3 hour algorithm. So it should be preferred whenever a high sensitivity troponin assay with a validated algorithm is available. And finally, additional biomarkers, for example, fatty acid binding protein or copeptin, are not routinely recommended for the diagnosis. So what is even more challenging, that's not only the diagnosis, it's the crowding of patients in emergency departments. Almost everywhere in the world, we face the same problem. And on the left side, you can see a typical picture on how working conditions are. It's very terrible, both for medical staff, but also for the patients. And to reduce their time in ED is a major goal. So either to discharge them or to admit them, and of course, to make decisions earlier. And the numbers of patients with infarct, as you can see on the right side of this panel, is stable or even slightly declining, whereas the patients who are admitted with chest pain to EDs is increasing. And that is probably also the reason is that they have no other chance to be admitted or cannot be seen by primary care physicians. So the only way they can see a doctor is by admittance to an emergency department. And most of them, 90% of these people, they have unspecific chest pain and can be discharged rapidly. So what we urgently need is a fast protocol, faster than before, in order to handle this problem. So what about the validation of these protocols in real life? Because we know that the clinical trials and real life is very different. And before, the validation studies for the 0 and 1 hour algorithm were retrospective validation studies. The physicians in the wards were blinded to the new troponin assays. They did not follow a discharge policy after 0 and 1 hour, but they did their routine management. So the safety of discharge following a 0 and 1 hour protocol cannot be based on the validation studies that were made from observational studies. So the new evidence has been cited in the ESC 2020 guidelines is there are two real-world evidence prospective registries. The one is from Heidelberg. The second is co-elaboration between Basel and Buenos Aires in Argentina. And then finally, we have so-called randomized intervention study, the rapid TNT study, that compared 0-1 to a standard 0 and 3 hour algorithm in Australia. So I will show advantages, strengths, and limitations based on this new evidence. So shortly to the rapid TNT study, the TNT study randomized 3,300 patients to standard of care or to the new experimental protocol. And the result of this study was no difference in the primary endpoint that consisted of 30-day death or myocardial infarction between standard and 0 and 1 hour protocol. And this means that there is not inferior protocol. You can use it without discharging patients at higher risk for death or MI, and it's just speeding up your processes. The only disadvantage of this study was that in the standard of care arm, the physicians were blinded to troponin values below 29. So all values between 14 and 29 disadvantaged the standard protocol a little bit. So overall, these three studies, the two real-world evidence studies and the randomized trial, find a very good performance of the 0 and 1 hour protocol with the achievement to rule out and to rule in patients in 75 to 84% of all cases, so mostly rule out and rule in, but they are leaving also an observational zone here in the middle. So patients who do not fulfill rule out criteria or rule in criteria, and these patients, they pose an additional diagnostic workup and observation time for physicians. What about the safety of these studies? Safety regarding the rule out patients, because most of them were also triaged to discharge, but some of them were judged higher risk by the treating physicians and were admitted. So they were ruled out, but also admitted. But if you look at the safety, we can see that in all three studies, the rule out patients had 30-day mortality or MACE rate between 0.2 and 0.4%. And those who were deemed eligible for discharge had a very, very small event rate of below 0.1%, 0.1% in BABA and 0.3% in rapid TNT. So this is a very, very low event rate at 30 days after rule out in low risk patients. So what about the length of stay in ED? This is one of the major advantages. You reduce the length of stay in ED, you can decongest your overcrowded emergency department. And as you can see in all three studies, there was a highly significant reduction of length of stay between 1 hour and 2.225 hours in the respective trials. The next finding is the discharge rate. So how many patients can you discharge home? Not referred to the hospital. This is discharge home. And you can see that again, you have a highly significant increase in the discharge rate. And that is from 8.9% to 12.8%. And for example, in Heidelberg, the rapid CPU, we already used the 0 and 3 hour protocol extensively. So an additional increase of discharge rate by almost 9% is a very good finding. And then many people are afraid that the resources that are spent to allow a safe discharge of patients will increase, or that even the coronary angiography rates will increase because of the use of a high sensitivity troponin assay, and that is not the case. So what we have here on the left side is that there were no significant differences in the use of coronary angiography within 30 days in the studies, and also with the use of 0 and 1 hour algorithm, functional testing means stress echo or stress MRI or stress EKG within 30 days was even reduced. And then finally, to summarize all the evidence, even including the observational trials that I mentioned before, meta-analysis was performed. It was published last year. That meta-analysis included more than 11,000 patients from 10 cohorts worldwide. So that includes the Middle East and Asia and Europe. And overall, we can see that the performance is excellent. I picked up here on the bottom sensitivity and negative predictive value. So that is the key measures for rule out, and they are excellent. So you have a 99.6% negative predictive value for this protocol. And regarding outcomes, you can see here the values for 30-day mortality and for 1-year mortality. So in the rule out cohort, 0.1%, rule in 2.4%, and observed zone 0.7%. What you can also see here is that the observed zone is very problematic, and this requires further workup and testing and observation. You have to be very critical here because, as you can see, at 1 year, the mortality in the observed zone is 7.9%. So it's almost as high as in the rule in. So a patient who has a stable low to intermediate troponin elevation, no acute kinetic change, is almost at the same risk as a patient who has a rule in, who has an acute rise and or fall of his troponin or high troponin values. Be very careful on that. So what are maybe the obstacles, the shortcomings of the protocol? Are there any patient cohort where we have to be extremely careful? So here in the PACE study, we tested the performance of specific patient subsets on the performance for sensitivity for rule out. And as you can see, there was no gender difference, no difference with age for pre-existing coronary artery disease or for renal function. And that is for the single cutoff for the ESC0 protocol. The only thing that's different here, you can see here, there is a significant inferior performance for patients who are early presenters to the chest pain after chest pain episode. So if you have chest pain onset less than 2 hours before admission, then you should be very careful to rule out an infarct based on only one very low troponin values. Here, the serial measurement with repetition of troponin at 1 hour is recommended. Regarding the serial measurement, 0 and 1 hour, you can see that there is no significant difference across all these interesting subgroups. So it appears very safe, provided you use a serial strategy with at least 2 measurements. What about the missed rates of MI in the observational registries? This is an overview, a table that I prepared for a publication, and I listed here on the top the respective observational trials, including the Scottish high stakes trial with their patient numbers. And as you can see, the percent of missed MIs. So it means what would happen if you would continue to measure troponin and not discharge the patient following 0 and 1 hour algorithm. So what would be the missed MI rate? And you can see that's far below 1%. It ranges between 0.2 and 1.2% as an extreme. So usually it's far below 0.5% missed MI rate. What is the obstacle? The obstacle of high sensitivity troponins and the fast protocols is that the implementation worldwide is lagging behind. Despite all these advantages that I mentioned, people in the world, emergency physicians, are not keen to use these protocols. And in particular, the use of the fast protocols, 01, 02, 03, are lagging much behind. And you can see that here on the columns across the world, in MEA, Latin America, Europe, in Asia. You can see that the 0 and 1 hour algorithm, it is 1B recommendation in the ESC guidelines, is being used at the most 10%, 15% of patients, usually worldwide, maximal 10% of hospitals use this protocol. They are afraid to use it. So coming back to the protocol, what do we need to know as a principle? The principle of this 0 and 1 hour protocol is that we consider both the magnitude of the baseline value and the concentration change within a very short time period. And if you have very low troponin, or you have and you have very low concentration changes within 1 hour, this is the principle, you can rule out the patient. So he does not have relevant myocardial injury, and he does not have an acute concentration change. The principle for rule in is you have either very high troponin concentrations, so that indicates the presence of myocardial injury beyond doubt, or you have a relevant concentration change, because this signals that you have an acute myocardial injury. And that together narrows the probability that you have any other disease that also goes along with high troponin. For example, the higher the baseline troponin and the higher the concentration change, the less prevalent is a diagnosis of, let's say, myocarditis, pulmonary embolism, Takotsubo, or let's say fast atrial fibrillation. You have to know that for all troponin assays, the values that you have to insert are different. They are assay specific to be used. So, and therefore the guidelines list all assays that have been validated for the use in a 0 and 1 hour protocol. The same also applies for the 0 and 2 hour protocol, again with specific numbers. And because this is very difficult to remember, you should have something like a poster in the ED or something that you can wear in your pocket to look at it and then decide whether the patient is categorized into rule out, rule in, or the observed zone. What has been simplified for convenience, for more rapid adoption in the ED, is that the guideline authors now omitted the consideration of disease-specific cutoffs. So so-called comorbidity or sex-specific cutoffs are not required. For example, considering older age, renal dysfunction, or male or female gender. This would complicate things, and therefore the guidelines recommend the uniform use of cutoffs. And a second recommendation is to have fixed time points for blood sampling. Means you do not await for the result of the first troponin, because this costs time. And if you have a central laboratory that requires more than 60 minutes for reporting, this time delay would also translate to all other protocols. So if you use a 0 and 3 hour protocol, your reporting time is also delayed. So the guidelines recommend a fixed serial sampling. So the nurses collect the blood at admission after 1 hour, and then regarding, depending on the result, again at 3 hours for those who are in the observed zone. And now coming to point of care tests, and I'm coming slowly to the end. Point of care tests that are widely used in the primary care setting, they have a problem. This problem is lack of sensitivity. And I show you here the reporting of the previous and the current point of care test for troponin T. And what you can see is that the previous test started to report at concentrations above 40. The new assay now starts to report concentrations above 40. But as you can see here above, the high sensitivity troponin assay reports starting at 5 and also reports abnormal concentrations above 14. And you have all the way from 14 to 40 that would remain undetected if you rely your diagnosis on a point of care test. So point of care testing is helpful for rule in due to the specificity, but not for rule out until recently. Recently, there have emerged some point of care tests that fulfill the criteria of high sensitivity assays. And the first high sensitive troponin I assays on point of care platform have now been introduced. And one of them is the Mitsubishi PathFast or LSE PathFast assay. And he complies with the 0 and 1 hour algorithm, has specific concentrations that you can insert to have your rule out and rule in protocol. And this assay is also in the guidelines. The second thing is observational zone, I told you, is very problematic. And here in the middle, you can see in red the percentage of patients in observational zone across all observational studies that were done. And as I also mentioned, the outcomes in the observational zone are terrible at long-term follow-up. They are at least as adverse as rule-in. And another problem is how to differentiate type 1 from type 2 MI. You know, there's a specific pathology of type 1 MI, spontaneous rupture of plaque, thrombus formation. That's not present in type 2, but you know that the definition of type 2 varies across hospitals and nations and studies. So you can see here the reported prevalence of type 2 MIs is very, very variable. So that's an unresolved problem. But still, elevation of troponin anywhere in the ED is a problem across all disciplines: heart disease, orthopedic, gastrointestinal. Everywhere where you face an elevated troponin, these people have, probably because of structural heart disease, worse outcomes. So it's worth to see what is the underlying reason for troponin elevation. So they're not just ruled out for MI, they have something in the heart. So you must invest some infrastructure, some imaging, echo, and so forth to detect. So my last slide, my key messages: high sensitivity troponin assays and fast protocols, particularly 0, 1 and 0, 2 hours, are recommended by the guidelines with the level of evidence of 1B. The diagnostic performance is safe and very comparable across important subgroups, except very early presenters, and that only for the single rule out based on very low troponin concentrations. The use is safe, and the rate of missed MIs is less than 1% with fast protocols. And also the rate of death within 30 days is very low. So acceptance rate at 1% and even at 0.5% is met. To allow a more broader implementation, because this is lagging behind, the guidelines now propose uniform cutoffs and sampling blood at fixed time sampling intervals for 0 and 1 hour, and eventually also for the 3 hour. Type 2 MI is really a disturbing confounder. It's a very different horse than spontaneous MI. It's more complex. Patients have more comorbidities and different treatments. But regardless, the underlying reason, troponin elevation, is unfortunate. It's associated with worse outcomes. And regardless whether this is acute or chronic, and you should find out the reason in the ED or in hospital and treat early and specifically. Thank you very much for your audience.
Thanks, Dr. Evangelos. This is a great summary of the rollout. And again, to our colleagues, the attendees, please, if you have any questions related to the talks, please put your questions so we can discuss it at the end of this session. Our next speaker, Dr. Leila Abdul Warith, Chair of Lab Pathology and Lab Medicine at Cleveland Clinic Abu Dhabi, and a Deputy CEO and Chief Scientific Officer at the National Reference Lab, is going to talk to us about implementation of high sensitivity troponin in a hospital setting. Dr. Leila. Dr. Leila, of course, is on the panel for the guidelines, Asia Pacific guidelines for biomarkers. So she will bring that experience into her talk, inshallah.
Thank you very much, Dr. Abdel Majid, and thank you very much really for the kind invitation to be speaking today in this great webinar. I have no disclosures really, and what I'm aiming to do today is just show you a simple case study of how we implemented high sensitivity troponin at the Cleveland Clinic, Abu Dhabi, what were the obstacles that we face, and what were the strategies that we adopted, and also highlight for our laboratory colleagues also what do they need to know before implementing high sensitivity troponin assays in their laboratories. So as Dr. Evangelos clearly and elegantly shared with us earlier, the benefits of the implementation of high sensitivity troponins are many. Early detection, mainly of acute myocardial infarction, which is very important in effective triaging in the ED department. Again, decrease length of stay in the ED departments and increase the ED discharge rates. It also increased our ability to detect type 1 MI, and also increased our ability also to detect type 2 MIs as well. So what are the challenges? The challenges, exactly as also Dr. Evangelos described, is that there are many other conditions actually that could also lead to elevation of high sensitivity troponin that are not necessarily related to an acute myocardial infarction or acute ischemic episode. And the key point here to remember is that elevated high sensitivity troponin identifies the presence of myocardial injury, but it does not really reveal the mechanism of that injury. So, you know, in that table here, the differential diagnosis will obviously include injury because of ischemia, whether this is a type 1 or a type 2 MI, or direct myocardial injury because of trauma or cardiotoxic agents or myocarditis, or other comorbid systemic conditions such as chronic renal failure, arrhythmias, pulmonary embolism, cardiomyopathy, stroke, subarachnoid hemorrhage, sepsis, etc. So this is the main thing that everybody should be aware of. So having said that, now I'll go and share with you very quickly our experience. And just to give you a bit of a background, the Cleveland Clinic Abu Dhabi opened its door in 2015. And since its inception, actually, we've implemented the contemporary troponin T assays. At that time, I requested that we implement high sensitivity troponin, but that was rejected. And the reason were multiple, actually, reasons. First of all, the troponin assay, high sensitive one at that time, was not still FDA approved. It was CE marked, and it was already used in many European countries as well as the UAE, but it wasn't still FDA approved at that time. Our cardiologists who came to start off at Cleveland, they were mostly from the main campus, from CCF, Cleveland, Ohio, and they were following the CCF protocols. And at that time, CCF were not implementing high sensitivity troponins. We had limited number of cardiologists, so they feared, obviously, that, you know, with the very limited resources, that this is going to be a huge burden on them. So I got them an opportunity in 2018. In the summer of 2018, the high sensitivity troponin T assays received the FDA approval, and our colleagues in the main campus at Cleveland Clinic, Ohio, started implementing it in the ED setting. So at that time also, as an organization, the number of cardiologists grew, and I thought now it's the time again to reopen the discussion about implementing high sensitivity troponin. So we had a multidisciplinary team. Of course, I was the instigator here from the lab, but truly the person who took it on and really drove this forward was really my colleague in cardiology, as well as my colleagues in internal medicine and emergency department as well. There were many discussion points that we had to discuss. Where are we going to implement this? Only in the ED or all over the hospital? Which algorithm are we going to use? The 0-1 hour, 0-3 hour? What is the rules and responsibilities of the ED physician, hospital medicine physician, cardiologist, and who's going to educate physicians? How can we use informatics? And I think Dr. Rabah will be talking to us about the role of that. as well if that can enhance interpretation or the algorithms. And should we build an older set, et cetera, et cetera. Of course, from the clinical pathologist perspective, you know, we were all very excited from the lab. We have a better assay, improved precision, increased sensitivity, less interferences, quicker to perform, and we thought this is a winning card. Our cardiologists, though, were very concerned, and basically they shared with us their concerns that really this is going to be a challenge for them to deal with the low abnormal values. And it wasn't at that point clear if the low specificity will lead to misdiagnosis, inappropriate testing, increased costs, and associated complications. So they feared that this will all lead to increased referrals, consultations, increased burden on a small team, increased invasive procedures, increased admissions, and increased cost of care. So they were really very, very concerned. Our emergency colleagues were very happy for us to do that. They were so excited, and they really wanted the adoption because of all the reasons mentioned before. Hospital medicine colleagues were kind of in the middle, but they were also concerned about the increased number of admissions. So we had to adopt many strategies to kind of overcome these obstacles. And the first one was we agreed to adopt the universal definition of, acute myocardial infarction, which is, a rise and fall. So you have to have that kinetic change in the high sensitivity troponin, at least one value above the 99th percentile in a context of coronary ischemia. And strategy number two is use something to increase the pre-test likelihood. We were already at CCD at that time implementing the heart risk score to risk stratify patients as they come in the ED departments with chest pain. So the only modification that we had to do to the heart score is just adopt now the levels from the high sensitivity troponin. But we decided to continue to use the heart score. And then the third important strategy was to agree on a decision tree protocol on the algorithm. That was the most critical step and perhaps the most time-consuming step, and I will explain this in a minute. So we had several attempts, actually 2 attempts at it. As I said, it was mainly driven by my colleague, Dr. Ahmed Idris, our cardiologist, consultant cardiologist who led this project at CCED. And initially what Dr. Ahmed wanted is, a very careful, very well laid out protocol. And he wanted to use the heart score first to risk stratify those patients. And based on the heart score, then we look at the troponin, the high sensitivity troponin, and we look at other confounding factors, whether it's a renal failure, morbid obesity, and all that, and then go another layer of classification and then agree whether it's a cardiology consult, a hospital medicine consult, or a discharge. He also focused on the low risk patients. Those are patients with a low high score, and for them, he then wanted to apply basically the rule out, rule in algorithm based on the troponin value and the delta. As you can see, this algorithm was a complicated algorithm. Emergency physicians didn't like it. Hospital medicine didn't like it. So we had to start all over again at that point. Then Dr. Ahmed came with a very nice protocol. Following that. And the first step now is to do the high sensitivity troponin. And then based on the high sensitivity troponin results and the deltas, you then have the rule out, rule in, and then the observational zone. Following that, you apply the heart risk score. And then depending on where you end up with the heart risk score, this could be a discharge home, or ED observation and another troponin in 3 hours, or admission to hospital medicine, or admission to cardiology. So again, that was a much simpler protocol. Everybody loved it, and we implemented it. And just to show you an example of a case here that he also used to drive the message, for example, it's a 59-year-old male, history of chronic kidney disease, diabetes, hypertension, hyperlipidemia, presenting with worsening of shortness of breath. The patient recently, he started hemodialysis, but he missed his session. The exams showed some crackles. The because of mild measure clackers, and then the basic metabolic panel showed elevated creatinine and decreased EGFR as expected in a chronic kidney disease patient. But voila, the high sensitive troponin is 62. So it is in the rule-in already. This is above 52. That's already an elevated high sensitive troponin value. And then the 1 hour value was kind of iffy, 66. So you have a delta of 4. ECG is pretty much normal, more or less. Chest X-ray, well, we have the catheter here for the dialysis. Perhaps the heart is a little bit enlarged. You have a little bit of fluids here in the lung. So if you were to apply the heart score, then based on the history alone, there is a moderate suspicion. So he gets a score of 1. ECG is normal. He gets a 0. His age gives him a 1, a score of 1 again. Because he has more than 3 risk factors, he gets a score of 2, and already his troponin, high sensitive troponin, is above 3 times the upper limit, so he gets a score of 2. So the overall heart score is 6. So if you put that in the algorithm, this patient is a rule-in. And because the heart score is kind of in the low to intermediate range, he would be then admitted to hospital medicine for further workup and interventions. Strategy number 4, actually, it was also another one that took some discussions, was to limit the use of high sensitivity troponin only to ED physicians and cardiologists. I.e. not to have it available for internal medicine colleagues or surgeons or intensivists or primary health care. That also took a lot of heated debates, discussions, but the people who were for this decision argued that the 1 hour protocol is validated only for ED and it should only be applied in the ED settings. Thank you very much. And then the use of a high sensitive troponin versus contemporary troponin is not really associated with lower MI or cardiovascular deaths. And then in the hospital setting, in the inpatient setting, you have relatively high percentage of patients with other acute comorbid conditions, such as sepsis, stroke, and so on. And then the patients in the ED departments. And then finally, in the outpatient settings, the challenges in the, with chronic diseases such as chronic heart failure or congestive heart failure or chronic kidney disease. Of course, the hospital medicine were very offended because of that. And they was just arguing that this is not in the best interest and it is going to disrupt continuity of care. It's going to confuse medical staff. It may actually potentially delay the diagnosis on the floors. And for us in the lab, we were like, okay, how are we going to do this? I just want to say here, this is a very nice paper we found published by GACC, and it actually gives a very nice set of recommendations for institutions transitioning to high sensitivity troponin. I urge everyone to read it. But the recommendation really is to use it in the ED department as well in the inpatient department, but to apply perhaps different protocols for the inpatients, maybe based mostly on the baseline and 3 hour sampling protocol rather than 0-1 hour, and also consider both clinical scenarios and confounding conditions. Is the patient have kidney disease, is it sepsis, pulmonary embolism, and so on. And also they have good guidance on testing around perioperative testing for non-cardiac surgery conditions as well. This is phase 2 now. We haven't adopted this, but I'm hoping that we embark on this hopefully soon. The 5th and last strategy, really the education and dissemination. We used every possible vehicle for us. So Dr. Ahmed was our champion for this. He went and attended almost every single clinical meetings. He met with the ED physicians. He met with the cardiologists, hospital medicine, grand rounds, chairs, medical executive committee meeting, nursing meetings. And he had lovely case scenarios that he shared with the group to kind of try to highlight how to implement the algorithm, address all the fears, all the questions. And then together with that, we kind of sent several emails and bulletins on regular basis just prior to the go live, telling everybody that we're gonna go live with this, guys, and these are the changes that you need to be aware of, and so on, until we finally transitioned and move over. Just in my last slides, I like to also explain here that, all I talked about was what the hospital and the emergency department and the cardiologists did to prepare for this. But there's also a whole lot of work that clinical laboratories have to consider before moving to high sensitivity troponins in their settings. And these are clearly described in the practice guidelines for the labs. They have to decide which cutoff to use and what kind of flagging. So our emergency colleagues wanted anything above 5 nanogram to flag. And then we said, well, should we flag based on the algorithm, the 12 nanogram per liter, or should we flag based on the 99th percentile, which is 14 nanogram? At the end, we agreed that we will flag at 14 nanogram, and we will also flag the delta, the difference between the 0 and 1 hour. The unit of measure, very important. You have to have very good precision at very small concentration, and you need to test that, and you need to test your measurement of uncertainty around these values. Which cutoffs to use, as elaborated by Dr. Evangelos, and then whether you're going to put an order set, for example. Initially, we started with what we call a rapid rule-out rule set, which calls for a 0 hour and 1 hour, so then our nursing colleagues will not miss the 1 hour sample, and also it calculates the delta for them right away. We subsequently had to actually inactivate it because it wasn't really that useful at the end, and people then got used to the protocol. The QCs you're supposed to use, again, you have to challenge your limit of detection. You also need to challenge your 99th percentile cutoff, and you need to challenge your upper measurement range. And the QCs should perform at imprecision less than 10% in all those levels. Education about the unit of measure is key, and we went about and talked to physicians and tried to educate them in the simplest way. Say, if you see a whole number, no decimal point, this is the high sensitivity troponin results. It usually is in nanograms, and you usually see it in whole numbers. If it's in a decimal point, this is a contemporary troponin. And now you have to also be aware that there are labs out there still in Abu Dhabi and all over the United Arab Emirates that are mixing these units. So they may be using contemporary assays, and they're using the nanogram per liter a unit of measure, or they are using high sensitivity assays and they are reporting them in microgram per liter. So please read carefully whether this is a high sensitivity troponin assay or a contemporary, which will just say troponin next to it. As Dr. Evangelos mentioned, in the guidelines recommend 60 minutes from blood collection to reporting, which means in your lab, it should be really less than 30 minutes, which poses obviously a huge challenge. Very important to make your physicians aware, as well as your laboratory technologists, aware of the effect of pre-analytic variables such as hemolysis, especially if you're applying the 0 and 1 hour protocol. If the 1 hour sample is hemolyzed, this is actually going to give you a falsely low high sensitive troponin value. And we had the technologists stopping the line, calling the emergency department, calling the physicians, insisting that they should send another sample because the sample is hemolyzed. You have to have means to detect hemolysis in your analyzers and flag that to your emergency physician colleagues. Be very careful about the IV contamination. Again, the T and I comparison. Beta interferences is not of an issue now. Roche assays have managed to overcome this, so that's less of an issue for us. Again, the discussion about point of care versus a main lab and your calibration frequency and lot-to-lot variation. So in conclusion, I just hope I can just share with you that, or at least impress upon you, that each institution really should implement a testing strategy that meets the specific needs and requirements of that particular environment or that particular setting. Education and multidisciplinary team involvement are really keys to the success. You have to be patient, you have to listen, you have to talk about these things and see how we can address these obstacles. The lab implementation of high sensitivity assays is very important, and you need to really stick to the practice recommendations there as laboratory professionals. And then just a final request for Dr. Abdul Majid and to the Emirates Society of Cardiology if they should really consider developing kind of a unified guidelines for the UAE on the implementation and the practice of use of high sensitivity troponin. This is just an acknowledgement. These are the team members. Again, I just want to highlight the incredible role really of Dr. Ahmed Idris from the cardiology department. At one point, I thought I'm going to lose him because he just was completely frustrated trying to find the best algorithm to use, but he persevered and took us to the finish line. Dr. Mahmoud Al-Hawamda, chair of hospital medicine, my colleague, Dr. Michael Roger from the emergency department, and of course, my right and left-hand person in the laboratory, Mr. Gerald Cox, the supervisor of chemistry, and then our IT colleagues who really helped us, Mr. Srinaz and Ms. Azza, in putting these together. And these are my references, and thank you very much for your attention.
Amazing, Dr. Leila. I think it's a case study, and I think this lesson should all our colleagues in different hospitals, they should use this experience in developing, implementing, and getting the buy-in from all the different stakeholders, all the way to the details. It's impressive. Thank you for sharing this experience. We'll move next to Dr. Aisha Al-Ma'mari. Dr. Aisha is going to talk to us about chest pain of a cardiac organ in the emergency department, how to sort out who can go home safely and efficiently. I think this is the most difficult decision, compared to cardiologists. The challenge is who can go home, not who can be admitted. And our colleagues in the emergency department, I think those are the patients that makes you awake all night, when you send someone home and you're not sure. Dr. Aisha, please.
Assalamu alaikum. Thank you, Dr. Abdul Majid, and for ACS for the invite and the opportunity to dive in the kind of literature that we all want to read, but we try to avoid reading, if anything. And thanks to all, as well for the attendees. I mean, I'm impressed with the number of people who are interested in the subject, and not surprised though, given how common this chief complaint is and how worrisome when we have someone with chest pain in the ED, despite that we see many of them every single shift. So I'll go briefly over, or I'll give you guidance how to sort of get a background in the sort of history of where the concern come from. Why are we concerned about sort of the rollout, and we're concerned about sort of like the sensitivity of every single tool available or protocol available. And then we'll talk as well about chest pain scoring available for EDUs or validated for EDUs. And then I'll go quickly over the 0-1 versus 0-2 and 0-3 hour that have been mentioned by previous two speakers. However, we'll just touch base on the three of them from different perspective. And then we'll go over 6 case discussions very quickly as well. So I'll start with the case studies, and we'll come to them at the end of the talk. So Mr. Sultan, 70 years old from UAE, came into ED with central chest pain since 3 days on and off. He's known for end-stage renal disease, on hemodialysis, hypertensive, diabetic, the regular sort of past medical history of that age group in UAE, or most of them. And his ECG did show non-specific T wave changes. His first troponin, which is high sensitivity troponin to be specific, which is what we've been using in Abu Dhabi since few years, was 60 nanogram per liter, and he had a stress test that was normal about 6 months ago. Mr. Ram, 40 years old from Bangladesh, came in with chest pain, short of breath that started 2 hours ago. He's smoker, hypertensive. ECG was non-specific, so kind of normal sinus, there's no really kind of changes in there. And his first troponin was less than 5, so kind of within the normal limit, or the first sort of like kind of first reading was normal limit. Mr. Martin, 65 from Australia, came in with left-sided chest pain that lasted for about 20 minutes, has been on and off since 2 weeks. He's known for ischemic heart disease, hypertensive. His ECG showed normal sinus rhythm, and his troponin as well, first one, was normal. Now, Mr. MA 31 years old from Palestine. And I'm not going to kind of mention the name, but these are 3 celebrities that can show up in your ED. And I'm sure every single one of us will be very careful when they want to tell them you have nothing, you should go home. And that's how we should think about with every single patient, despite their social status is. So he came in with central chest pain that has been there for 4 hours continuous. He doesn't have any past medical history. He's not a smoker. He does run 10 kilometers daily. His ECG was normal and troponin normal. Mrs. SK, 51 years old, originally from India, who presented with chest tightness, feeling anxious since 2 hours. She was in UAE attending a nephew wedding. She doesn't have any past medical history. Her ECG was normal and troponin was 6 nanogram per liter. Mr. CR, 36 years old from Portugal, who came in with chest pain since 5 hours post a football match. He doesn't have any past medical history. His ECG had a heart rate of 45 sinus bradycardia, and his troponin, first troponin, was 58. So keep them in mind. I'm not going to discuss them now, but we'll touch base on them at the end of the talk. So if you sort of want to know how, I mean, I'm sure every one of you does appreciate how extensive the literature are about acute coronary syndrome and chest pain. This review article that you can purchase online, or if you have access to emergency medical report, you can find it. If you would like a copy, I'm happy to share my copy with you as well. So simply they had reviewed all literature about ACS that's related to emergency department practice. And for you just kind of to see the size of literature that was there till 2017, Cochrane Library had 77 articles, National Guideline Clearinghouse had 104. And when you just go in the literature, you say ACS, about over 1,000 articles. So they had gone through that and they have summarized it and critically appraised it and presented that in a very organized fashion. So that would be a good sort of summary article for you to read till 2017. That would save you sort of a lot of literature search if you don't have the time to sort of do it yourself. Now, from that article, if you want to sort of focus on where kind of our concern comes from. So in 2000, this article was published that had showed that rate of missed MI was 2% almost. Data was collected between 1993 and 2000. So if you go back then, they were not yet using troponin. CKMB was the biomarker that was in use. 2002 to 2003, this was sort of like a retrospective study that was done in Canada. And they were as well kind of interested. They wanted to know were they missing kind of MIs more or less similar to US or not. And they compared the high volume ED to low volume ED. And their conclusion at the end was they had about 19,000 patients that in high volume ED, they missed about 2%. So more or less similar to US back then. And low volume ED had 2-fold higher odds of missing an MI. Now, back then in 2003, where in low volume ED, which is usually in the periphery remote area, where you may not have a board certified emergency physician working, you may not have access to cardiologist on call or someone who can support you, then your likelihood of missing MI would be higher. So back then the advocacy was for telemedicine, which by now is becoming part of our practice, especially after COVID and all the events that happened over the past 2 years. 2007 to 2008, so this was a sort of a prospective study in France, small size in comparison to the previous two, 300 patients, and the rate of missed MI was 3%. Now, as well, to put it in perspective, high sensitivity troponin came into practice, as you heard from Dr. Leila. So in 2014 was not yet FDA approved. And for example, CCAD had implemented that in 2018, but many centers, many hospitals were slow in adopting them, just being careful, waiting to see how sort of they will implement them, number one. Number two is how safe they will be as well, or if not about safety as well, about sort of all logistic that may result from it. So this study was done with sort of the regular troponin, not the high sensitivity. Now, if we want to answer the question, how to sort out who can go home safely and efficiently, then you want to define what's low risk patient. So when we say he's low risk, he's high risk, what do we mean? So there are 3 ways to think about this definition. Clinical definition, which is simply hemodynamic stability. patient who does not have any concerning feature in his history, and that's an emphasis on how important history is with chest pain. What I always teach our trainees and residents is, with many complaints, I can trust any physician to see the patient, hand over to me or review with me, and I don't need to retake the history. With chest pain, it's always depending on your own history. So I would always double check chest pain history because it varies how you interpret what the patient tells you. Now, no ischemic changes in ECG and normal biomarker. So that's if you look at the clinical definition, what low risk would sort of kind of be defined as. Now, from outcome-based definition point of view, then you want the risk for the patient to be safely sent home to be less than 1% risk of MACE or death at 30 days. And then from practice-based definition would say patient who may be safely discharged home with little, if any, further testing. So someone who I'm going to send home, I'm not going to third to cardiology with maybe instruction if their symptom can changes or got worse or something, they can come back to the ED after that. So that's if we want to think about when we talk about sort of patient who are low risk as a definition, then there are three definitions, not only one. So keep that in mind when you kind of generally say he's low risk. So what do you mean? Do you mean low risk from outcome point of view? Or do you mean low risk from practice-based point of view or from clinical point of view? So how do you want to start? I mean, history is always the key. 90% of our diagnosis would be led by history. Exam, ECG, and biomarkers specifically for chest pain. Now I'll make it easier. I'm going to cross out exam. And crossing out exam does not mean you're not going to do it. You're going to do it, but it's going to be normal in most patients with low risk. So if your exam is normal, you're already kind of thinking you're in the low risk category, more or less. And then you're going to focus on your history, ECG, and biomarker and kind of go from there. If your exam starting being abnormal, then you would set even and focus more about your other differential, whether it's cardiac, non-cardiac. And if you think it's cardiac, then likely you're in the high risk, not in the low risk group. So some history element that highly suggests ACS would be, so acute coronary syndrome, would be pain radiating to both arms, pain similar to prior ischemia, change in pattern of pain over past 24 hours. As much as this could be basic, as much as we need to kind of remind ourselves of this point every now and then and every day as well. So these three factors predict ACS by sort of positive likelihood ratio of more than 2. So if you have one of these, or you have 2 of them, or the 3 of them, then you know you're really concerned about your patient. Now, this history element usually makes kind of ACS very unlikely. So 3 Bs, if you have pleuritic pain or pain that's positional or pain that's reproducible with palpation. So that's reassuring, does not rule it out, but kind of somewhat makes me a bit less concerned as a physician, right? So pain described as sharp or stabbing, pain not associated with exertion. And so these were the least predictive of ACS, more or less. Now, thinking when there is no time to think, ED physician would recognize this statement very well. Simply, when you are in the ED, when you are rushed, as much as we want to sit and take history and think and rethink again and discuss, as much as we don't have the time to do that. That's why part of our practice is clinical decision rules for different chief complaint, and as well clinical risk scores, where it does help us to go blindly, use the score, and then kind of from there go to the decision based on the decision-making tree. So chest pain clinical risk scores, there are many in the literature. What I summarize here are the sort of 5 most common that we always sort of see, discuss, or use, more or less. And I'll make it a bit easier for you. I'm going to cross out these 2. So TIMI, non-STE-ACS, and GRACE. So if you see here, the purpose of the study when it was done, so TIMI was derived 2000, it was for unstable angina, non-STEMI. So it's not for you undifferentiated chest pain that you think it might be ACS that's coming to you to ED. This is someone that was diagnosed unstable angina, non-STEMI, who's admitted. And now you want to predict the risk of death or ischemic event in order to guide therapy. Should we go and cath him? Should we do a non-stress test? Should we do other kind of other risk stratification issue? So simply it was not studied in ED population, not studied for the chief complaint or the patient population we're kind of trying to address. GRACE came in 2006. Simply was as well done. The purpose was to predict hospital and 6-month mortality in patient with ACS. So your patient already has ACS. Now you know predict their mortality and in hospital and 6-month mortality, right? And to guide as well how aggressive the treatment would be. So more or less designed for cardiology when they do have someone with ACS, how to move forward from there. Now the beauty of GRACE was validated in UAE, so I would have to use it if it was kind of was designed or derived for ED population. So now what do we have? The 3 most common that we always sort of discuss in our ED literature and that kind of validated in different population: the heart score, the ED, ACS, and Vancouver score. So heart score was derived in Netherlands, validated in different places, among them Japan, multiple places in USA and Singapore, and as well validated in Netherlands, of course. And then in the derivation rate, risk of missing ACS, in the derivation study, it was 2.5% for low risk. And then in the validation study, the rate was various, but always less than 2.5%. And then what perhaps makes it one of the kind of commonest scores that all of us among the ED physician community, we prefer to use the heart score. Now, ED-ACS was derived 2014 in Australia, and it was derived along with as well a 0-2 hour protocol back then. So it was validated in US, Canada, and Korea, and Australia as well. The derivation sensitivity was 100%. But one of the issues with the ED-ACS that the validation sensitivity has been variable from validation study to another validation study. So certain countries, perhaps they won't feel comfortable using it, but then that would make me as well concerned, how would it perform if I do validate ED-ACS in our population here in UAE or Middle East, for example. So MACE was 1.1% in low-risk patient overall. So I mean, if you go by 100% sensitivity, then you're not missing anyone, almost zero. But if you go by 88%, or if you go by 98%, there is some sort of patient that we are missing there. Vancouver chest pain, I mean, from the name you can tell it was derived in Canada, and as well it was derived with a 0-2 hour sort of protocol to sort of rule out patient very fast. And they used, so this is great because they used, for validation, they used the high sensitivity troponin in 2014. For the derivation, it was the regular troponin. And then it was validated in Australia as well. And the derivation was 100%. The second validation in Australia was 91%. So as well, some variation in outcome there. So now, if you would ask me, I would say any one of them perhaps would perform as well. But I would personally go with the heart score for the reason I mentioned. That seems to be consistently, if anything, we're less than 2%. And most validation study were kind of, I mean, 2 of them were 0%. And 2 of them were 1.5 on average. Now, RCTs that discuss 01, 02, 03, there are many of them out there. I did choose 3 of them, just kind of to put the 3 most popular or most recent. So the rapid TNT that Dr. Evangelist had mentioned in his talk initially, so it was recent 2019, and it was validating the European 0-1 hour protocol. It did use the high sensitivity troponin T, and it did compare, their comparison was the 0-3 hour as well using the high sensitivity troponin T. And they looked at MACE at 30 days as most, and mortality at 30 days as most sort of the studies are doing. So as Evangelist had pointed out, length of stay in the 0-1 hour was shorter. So it was on average 4.6 hours, while the 0-3 hour was about 5.6 hours. So about an hour difference, less length of stay. Now, when you have a busy ED, at times discharging someone 10 minutes earlier makes a big difference for us. Now, less cardiac testing. So they did less sort of objective cardiac testing, non-stress test, echo, and kind of other testing later than that. And then the negative predictive value, which is amazing, 99.6%. So your kind of risk of missing someone would be less than 0.5%, if anything. So this is sort of, if anything, I would say, when I read this article, I felt very comfortable with the 0-1 hour. Now, the ADAPT 2 hour accelerated diagnostic protocol was done in 2012 in Australia. What they did, they used ECG, TIMI score, which we just said it was not developed for ED, and 0-2-hour troponin I, and this was before the high sensitivity again, and compare that to standard of care. So it was a negative predictive value 99.7%. So it was amazing as well. They did not almost miss anyone. But I do have concern here about, again, using TIMI. And I think if anything, it need to be redone using high sensitivity, given that they're widely now used everywhere around the world. And then see how that performs, and then consider using that protocol of interest to you. The heart pathway seems to be as well kind of very popular, more or less, where this is the original study where they did the heart pathway. So you have heart score and heart pathway, and in a minute, I'll explain how they are different. So the heart pathway, 0-3 hour, and compare that to usual care, and it was done 2015, and they used as well, was Siemens Troponin I Ultra, so high sensitivity troponin. And what they wanted to see is objective cardiac testing and 30-day mortality as primary and secondary outcome. So they did reduce testing by 12% and ED length of stay by 12 hours. And 12 hours, again, as Evangelist had said in his talk, people were doing, the adoption of 0-1 hour, 0-2, and 0-3 has been a bit slow globally. And when I trained, we were doing 10-hour and 12-hour. And when we were talking about the 6-hour, many of the attendings were a bit kind of not comfortable with that. Though given all the sort of new literature and how we are overcrowded, and if we can safely discharge someone faster, would be beneficial for the other patients who are in the waiting room. So certainly, I think reducing that length of stay by 12 hours is simply you're cutting off many patients who usually you'll keep for observation. Now you're comfortably sending them home earlier. And then they had 0 MACE at 30 days for the low risk discharge. So the group that was categorized by heart pathway as low risk and to be discharged home, simply 0 MACE. So you're almost missing no one in there. So this is the heart pathway. So you start by doing the heart score. And for you to do the heart score, you need to have one troponin done. So if you remember the slide that Dr. Layla had said about the CCAD pathway, where they started with a troponin and then they do the heart score. So that's the way to do it. So one troponin to be done, then you because you need that to do the heart score. So you do the heart score. And then if you're in low risk category, you're going to repeat your second troponin. Now, if you're in the heart pathway, their protocol is 0 and 3 hour. And then if negative, you're going to simply early discharge that patient. Now, can you do this and go 0 and 1 hour using still the heart pathway? I would say that will be improvising if we do that, but that would need to be perhaps as well studied before we say yes, we can do that, because I'm not sure how that would perform, right? Now, this is the European guide, the recent European guideline 2020, and the 0-1 hour protocol that I'm not going to explain, because you'll need, one is to read the guideline, read the details of it and how to apply it, and already was explained in the first talk of today. ED-ACS, and the reason I put this slide here is because I'm going to share with you a recent study that was done, published in March 2021. So the ED-ACS, so you go on the risk score and then tell you low risk and tells you recommendation as well. So I would, if you're in emergency medicine practice, I would highly say you should go and look up this article and read it. So it was a prospective cohort, and patient recruitment happened between January 2018 and December 2019. To put it in perspective, data collection was done before COVID. I mean, COVID now perhaps may have changed things a little bit, which perhaps we're not sure as well if it had changed how we should risk stratify patient, but I'm not going to go into there. Though for me, it does make a difference to know that this data is not contaminated by another kind of factor that could be COVID playing a factor in there. So what they did derive risk stratification ACS, RISTRA ACS, and I'll explain in a minute what that is. And they compared it to heart score, heart pathway, ED-ACS, and physician gestalt, and troponin only. So what if you do troponin only, and based on that you decide? So the RISTRA ACS, risk stratification ACS, Simply, they're using EPIC as their medical record, electronic medical record, and they designed this formula where they use the heart score and EDACS, or one of them. They use that to calculate their sort of risk calculation. And then if you have heart low and EDACS low, then they go and they look at the troponin, and they had identified their cutoff for troponin. And then they, based on their sort of data collection, they put patient in risk group, and they give you the, like this would happen more or less from the electronic medical record, and it would give you the prediction. So after the troponin and all that, so what would be the prediction of risk for that specific patient? So if anything, I would imagine this would be peace of mind, because then, so what we're doing is we look up this calculator, and then with that calculator, and you try to kind of think and sort of put things together. But if you have something that would happen that would be trustworthy and sort of validated, that would give you that prediction for this specific patient based on the information in their medical record, that would be something definitely I'll be interested to try and explore. So how did that perform? So if you look at the sensitivity here in the third row, so for troponin only, if you're giving troponin, sensitivity 80%. EDACS alone was 89%. Heart score alone, 88%. So heart score, remember, heart score is one troponin only. And then if you go to the heart pathway, where you start with one troponin, low risk, high risk, then you do serial troponin, then 96.7%, so sensitivity is better. Restra ACS 97.6, so very comparable, which kind of very encouraging. Now, what was surprising for me and would likely make me sort of be a bit more vocal when I think I'm not comfortable sending someone home, despite the numbers looking good, is physician gestalt was 97.2% sensitive. So, which is key when you are seeing someone with chest pain, undifferentiated chest pain. If you don't feel comfortable that this patient is safe to go home, that means you should stop, reevaluate, and maybe get help from someone else, either cardiologist on call or your colleague. So do not ignore that sort of calling insight that tells you this patient may not be safe to go home. So if we go back to our case studies, so Mr. Sultan, if we go quickly, and for you to calculate heart score, you have to go to your calculator and plug the numbers in there. Now I've done Mr. Sultan before the talk, and simply he goes in the moderate risk score, just if you consider age, 2 high risk factor, and troponin being 60. And so simply he's a high risk, he's not a low risk. So he's not someone I'm gonna sort of, if troponin does not go, delta changes, I'm gonna feel comfortable sending him home quickly. And he's not someone where I'm gonna be very happy to do the 0-1 hour troponin. Likely this, like I'll tell you what I do is I've been adopting 0-1 hour for certain type of patient when my suspicion is a bit low, and when I think they fit in where the population was validated on them. But for population where I think they are a bit different risk profile and where their comorbidities are a bit so complex, that's where I think if I have 0-3 hour, if I keep them a bit longer, maybe I'll feel more comfortable. So if Mr. Sultan, let's say, stays with us and we repeat troponin in 3 hours and it does not change, and his symptoms by then are kind of better, and we repeat ECG and he's better, I may have some comfort to send him home. But given, and with a cardiology follow-up, of course. But if I do the 0-1 hour here, likely I'm not going to be comfortable. So that would be the calling. Now, looking at him this way, again, with the clinical assessment, you might decide to keep him, you may decide to send him home. But this will be someone that you will likely you'll think about him multiple times. It's not going to be easy. I'm going to send you home, right? Mr. Ram, and we all have been burned by someone who looks well, young, from Asian origin or South Asian origin, who comes in. We do the troponin normal, we do the ECG, you repeat troponin normal, you say go home, this is not cardiac chest pain. And then I can tell you there are a few cases, maybe one every 2-3 years that we hear about, where then in 24-48 hours, they are brought back in cardiac arrest. And then if you are the physician who had seen him, despite you have done what you needed to do, you definitely feel a little bit sort of guilty about it, thinking could have done anything different. So as well, risk profile for South Asian has been a little bit sort of different. So with these kind of population, I'm a little bit as well more careful, especially there's always language barrier, which make history not super reliable, even through translation. So that would be another factor to keep in mind. Mr. Martin. So Mr. Martin is a perfect patient for 0-1 hour. That's where the rapid TNT was validated in Australia. So Mr. Martin, 65 from Australia, left-sided chest pain, 20 minutes on and off since 2 weeks. So it has been on and off for 2 weeks, so a bit long time, it's not kind of short time. Yes, he is known for ischemic heart disease, but have a normal ECG, normal troponin. So him, I can easily do the 0-1 hour troponin normal. I'll be very happy. Send him home, follow up with your cardiologist, and figure out, for example, why this chest pain is sort of recurrent. Could it be stable angina? Could it be anything else? Now, Mr. ME. So Mr. ME, despite being Middle Eastern, however, when you look at his risk profile, he's definitely low risk. And if he goes in the heart pathway, he will be the easy as well rule out, where perhaps someone like him, young like him, where I say ACS should be unlikely, someone who runs 10 kilometers a day. If he did run 10 kilometers yesterday, I'm going to be very comfortable as well doing the 0-1 hour with. And again, I'm not, what I'm telling you, what I'm sharing here, I don't want you leaving here saying that I do recommend the 0-1 hour, although I do not recommend against it. But what I'm saying is that I do use my clinical gestalt, and I said I'm going to be more vocal about that to decide which patient I think will be safe to do 0-1 hour, and which patient maybe I'll go to 0-3 hour. Certainly, I'm not going above that. So Mrs. SK, so this lady, it would be tricky. Now, her chest pain has been only 2 hours, or chest tightness, right? So the 2 hours will keep her at the borderline. So if you remember as well, Evangelist had said, patients who are less than 2 hours, you have to be a bit careful because their chest pain is short term. So these are the patients you might need to do the 0-2 hour as per your being guideline, and not do the 0-1 hour for them. Now, Mr. CR, so he just finished a football match. His troponin is high, right? So again, with him, risk factors are not there. So bare heart pathway, what makes him a bit higher risk is the troponin. So if we do the, like with him again, troponin high, although he had run or kind of played the football, I would say that kind of sport has been the maybe kind of part of that troponin rise. Though I'll feel more comfortable with that, keeping him 3 hour, do the second one in 3 hour. Plus being celebrity, I don't want to be in the newspaper being the one who had missed his MI, to be honest. Now, what I did a few days ago, as was preparing kind of and reading the literature, I did a quick poll to my followers in Twitter, who most of them are emergency medicine physician. 23 had took the vote. And I wanted just to see the sense, how many are adopters of 0-1 hour? Because we've been kind of talking about it, willing to adopt it from flow perspective and efficiency perspective, yet still every one of us is a bit worried about missing an MI every now and then, and not willing to be in that kind of spot. So about 35% said they are pro 0-1 hour. 30% said they do the 0-3 hour. And I mean, you can't blame them, because if that's the guideline in their hospital, they'll have to follow that as well, or if that's what they feel comfortable with. And 13%, they said both based on the risk profile, and others said 22. So others, because I mean, again, you never know which country they're practicing in and all that. So based on where they are. But at least what I kind of learned from here, that I guess the dilemma where I feel myself, I'm not ready yet to adopt 0-1 for everyone. And I feel based on the patient, I kind of flex between 0-1, 0-2, 0-3. I think many of our kind of colleagues are still sort of in that place. So I'll conclude by telling you, and if you remember when we started, we were kind of going up the mountain. And if you have been hiking mountains, you will know that when you start, you're so enthusiastic, you want to reach to the summit. And once you reach to the summit, the bad memory comes that you have to go down, and then you feel you want to throw yourself up from there. So here is what that feeling kind of where this analogy comes from. Atypical chest pain. So someone who comes with very non-specific chest pain that does not sound cardiac. Normal ECG, normal high sensitivity cardiac troponin T. You can still miss 1 MI in 200 patients. That's the 0.5% rate of miss. So keeping that in mind, being careful when you apply these sort of risk profile, risk scoring, and when you apply the protocols to your patient population, to your practice, I would say do it as a group, as a department, as a country, rather than doing it as an individual. And don't change yourself before your team kind of being on the change as well. Because if you happen to miss an MI, you want that support for people to say that you had followed the standard, yet despite that you had missed MI. I mean, every now and then we're gonna miss someone, but as long as we follow the standard practice in the country, internationally, then we are in the kind of safe zone. So having consensus is important. Now, retrospective validation, if you start reading the literature, a lot of validation has been happening retrospective, especially with electronic medical record has been now available since 10 plus years. So you can easily go on retrospective, pull your data, mine the data, and then see how sort of like if you apply this protocol to retrospective data, how that would perform. And then if it's feasible to plan prospective, perhaps go for it. If not, I would say at least having something retrospective would give us some assurance where we are with our patient population. And where I would say never ignore your clinical judgment. It's always a key, and it always saves us multiple times in the emergency department. Thank you so much for your attention. And at the end, I'll be happy to answer questions.
Thank you, Dr. Aisha. I think, it's as you said, it's a dilemma for the emergency, and that's why we give you more time, because it is the emergency physician's challenge for the rule out and the discharge. But I think now we're starting to get tight in terms of time, and we have Dr. Salama and Dr. Rabi, and we want, we want also to save some time for the discussion. So we'll move to Dr. Salama from, primary healthcare and a family medicine perspective. And Dr. Salama got a case, and that can also stimulate the discussion later on. We got a good number of questions. I can see them up there, so we want to address them properly also. So Dr. Salama,
good evening.
Focus. دكتور عائشة أكلت وقتك.
Thank you for inviting me to be a speaker in this valuable webinar session today. I will start with a case discussion that we have encountered in one of our remote clinics, and then we will go through a discussion whether troponin testing should be ordered in the primary care setting, as it is a very challenging topic to the primary healthcare physician. So this is a 50-year-old male who's known to have hypertension, hyperlipidemia, and prediabetes. He presented to one of our remote clinics with chest pain. The pain is centrally located, which is radiating to the left shoulder and jaw, and it was aching in nature. It was moderate in severity, which was constant and lasted for 2 hours, and it occurred at rest. The associated symptom consists of dizziness, dyspnea, nausea, and epigastric pain, and there were no any modifying factors. The patient social history, he's married, full-time employee, and he's non-smoker. And the family history is that his mother is hypertensive. So upon physical examination, his temperature was around 37.3 degrees with the pulse rate of 98 beats per minute, respiratory rate 18, and his blood pressure was elevated around 165/101, and oxygen saturation was 100% on room air. So on physical examination, it was within normal limit, except that he had some chest wall tenderness and decrease in chest wall expansion. We performed initial ECG and repeated ECG for the patient, which revealed ST depression in multiple leads. This was the repeated also ECG. And therefore, the chest X-ray was also performed in the clinic, which was normal and clear chest. Troponin I-stat was performed, which showed the critical result. And therefore, the patient was loaded with aspirin and clopidogrel in the clinic and transferred to the nearest hospital. So in the hospital, he was admitted as a case of chest pain with non-ST elevation MI and with anterior Q wave changes. A bedside echo was performed to him at that time, which showed the apical and distal posterior wall akinesia with mild MR and the ejection fraction of 35%. The troponin T was also elevated, around 2,685 nanogram per liter. So this is as per the interpretation of our labs. The patient underwent diagnostic coronary angiography and coronary angioplasty of the mid-LAD with drug-eluting stent. The mid-LAD had 100% thrombotic occlusion. So basically, as we know that chest pain is a common presentation in general practice and emergency departments. The causes of chest pain presentation, it can vary from benign and self-limiting, such as musculoskeletal chest wall pain, to potentially life-threatening conditions such as acute coronary syndrome, aortic dissection, or pulmonary embolism. I think I lost my presentation. Okay, so appropriate clinical assessment of chest pain must include comprehensive history taking, which is very important, including the cardiovascular risk factor assessment and a thorough physical examination, and then the performance of the 12 ECG lead. Now, when it comes to the point of care troponin testing, of course, it has been emerged as a clinical tool, and whether I cannot see my whole slide, just a moment. Yeah, okay, so when it comes to point of care troponin testing, it has emerged as a clinical tool that can be used to provide a rapid result when access to hospital or lab services may be limited. Point of care troponin testing does not require any sample preparation or lengthy setup procedures. It can be used in places where heart attack patients are often seen first, such as in land or air ambulance, emergency rooms, or like in a primary care setting where the healthcare professional in rural healthcare centers or remote locations can use them. Of course, it depends on the manufacturer device. It varies in their sensitivity and specificity. And they are likely to have an emerging role in analyzing chest pain in primary care. So here, when it comes to ordering of troponin in central laboratory testing, it takes around 60 minutes for the result to be issued to the clinician. And when ordering troponin through the point of care testing, it takes around 15 minutes for the results to be available to the clinicians. So just a quick reminder on what are the causes that can elevate troponin in the absence of an acute coronary syndrome. We have some of the cardiac causes and non-cardiac causes. The cardiac causes such as cardiac contusion, cardiac surgery, post-electrophysiological procedures such as ablation or pacemaker implantation, aortic dissection, aortic valve disease, hypertrophic cardiomyopathy, tachyarrhythmias, infiltrative diseases such as amyloidosis, hemochromatosis, sarcoidosis, and scleroderma, and inflammatory diseases such as myocarditis. The non-cardiac causes such as rhabdomyolysis, pulmonary embolism, and severe pulmonary hypertension, renal failure, acute neurological diseases such as CVA and subarachnoid hemorrhage, critical ill patient, those with respiratory failure or sepsis, and those who under extreme exertion. So when might it be appropriate to order a troponin test in general practice? And really, this is very challenging to all of the physicians in the primary care setting, and even it keeps us like in dilemma. So ordering a troponin test in the community setting should be done carefully and cautiously. Troponin testing should not delay referral of patient with suspected acute coronary syndrome to the hospital, as this can lead to increased in morbidity and mortality. It's not appropriate to measure serial troponin levels in the community, especially like in primary care setting, as the patient will not be monitored for possible worsening symptoms and potential complication. It is also not recommended to measure troponin in asymptomatic patients or to use troponin as a screening tool, as the result may be problematic with no clear management strategy and could lead to unnecessary investigations. If the troponin test is ordered in the primary care settings in community, it should be clearly marked as urgent, and there should be a mechanism in place for the doctor and for the healthcare centers and patient to be contacted with the results. If these logistics are not in place, this could lead to potential delay with follow-up of positive results. The patient could potentially be in the community with an elevated troponin level without adequate follow-up and not receiving appropriate clinical care. So therefore, as a consequence, the degree of MI may extend and the patient could experience serious ventricular arrhythmias. If there is a lack of capacity to receive troponin result and arrange appropriate clinical follow-up when performed in the community, example like late in the day or during weekends, then a referral to an emergency department is appropriate. Patients presenting with possible acute coronary symptoms and syndrome and symptoms occurring within the previous 24 hours should be promptly referred and transported to a hospital emergency department. The absence of an elevated troponin does not exclude unstable angina, and urgent cardiac assessment is worth, and it is still appropriate if the presenting symptoms are highly suggestive of acute coronary syndrome. And the troponin testing should not be ordered unless there is a mechanism to review the result as soon as it is available. And I'm referring here to the primary care settings. So in conclusion, the cardiac troponin is a serum biomarker used as a diagnostic tool to detect myocardial damage. And the primary care physician should be vigilant enough to refer patient immediately to hospital when presenting with symptoms suggestive of acute coronary syndrome. And the primary care physicians should take care when ordering a troponin test to ensure that the result is communicated promptly and there is a mechanism in place for the patient to be contacted if required. So this is all from my side, and thank you very much.
Thank you, Dr. Salama. I think, you know, a very good case, and, you know, it illustrates that, you know, sometimes, you can find a high risk type of patients in, in a primary healthcare setting, where you have to pick him from all the spectrum of diseases that you're seeing in your busy daily practice. So you have to have a good tool to help you make a decision like a point of care. We'll move to our last talk in this session, which is a very important talk by Dr. Rabia, and he's, Dr. Rabia is the professor of medicine at the St. Joseph University in Beirut, and he worked on the guidelines in Lebanon, and also, had it moved into practical application, which is, integrating into informatics to help get to the point of care for the physicians. So, Dr. Rabi, please go ahead and share with us your slides.
Okay, sorry, so I was muted. Thank you, Dr. Abdel Majid. It's a pleasure to be with you tonight, and it's a pleasure to be with all our colleagues from the Emirate Society of Cardiology. So in the remaining time, I am going to discuss the Lebanese guidelines, what we did to implement the troponin test.
Try to get a 10-minute for the questions, Dr. Rabi, if you don't mind.
Sure, sure. So let me move then quickly. You know that the troponins are a key player in the algorithm for non-ST elevation acute coronary syndromes, and that there have been several protocols which were already discussed. Now, what I want to emphasize here is that those highly sensitive assays can detect troponin in people who do not have acute coronary syndrome. So you can measure troponin on everyone. So what's important is the delta, the change in troponin over time. Because if the troponin is very high, then the diagnosis is clear and you don't need a sensitive assay. So what's important is to detect those minor changes very early after the onset of ischemia or of chest pain, and make the diagnosis very quickly. And this change in troponin can be, evaluated as an absolute change, absolute delta change, for example, 7 or 5 or 3, or it can be also evaluated as a relative change. And this definition is used when the first level of troponin is higher than the 99th percentile. So when we are below the 99th percentile, we use absolute delta change. And when we are above the 99th percentile, we use a relative change from the baseline level. And as was outlined by the previous speakers, there are several algorithms using the 0, 1 hour, 2 hour, 3 hour, or other algorithms that were also discussed. For example, if you want to combine the 0, 1 hour algorithm with the heart score or with any other scores, in order to improve the specificity or the sensitivity. So it becomes a little bit complicated. And by using those algorithms, as you see here on this slide, you can reach a high negative predictive value. You know, with a standard assay, you are at 97% negative predictive value, but with the high sensitivity assays, you can reach 99% of negative predictive value. But the problem is the following: you start losing your specificity. So if with the old assays, the positive predictive value of an MI was 72%, with the new assay, now this positive predictive value is only 15% because, as was mentioned, there are several other reasons for a high troponin. So we were aware here in Lebanon, and I think you agree with me, that with advancing technology, we have better diagnostic possibilities, but we also have room for more complexities and more errors. And such an example of the better diagnostic possibilities is what was already diagnosed. What was already discussed. We can diagnose smaller MI. We can diagnose them earlier. We can discharge our patient earlier or rule them in and out earlier. However, with the complexity and the errors may be multiple. And all of you are aware of this troponinitis syndrome, where everyone with a positive troponin, gets a cardiology consult, because we know that those troponins are elevated in conditions other than myocardial infarction. The other also problems that was, I think, discussed by Dr. Layla is the reporting of the new high sensitivity assay by those decimal numbers. So like 0.005 or a delta change of 0.002 or 0.003. So this may lead to confusion and mistakes. And finally, we have several high sensitivity troponin assays in the market. So which one should be used? So because of all those reasons, we decided in Lebanon to meet and to develop some national guidelines, which we did with the help of our friend Evangelos Giannitsis, who is with us tonight. So we wrote those guidelines and we published them this year in the Lebanese medical journal. And the baseline of those guidelines, the core of those guidelines were the adoption of the universal definition of myocardial infarction, where the detection of a rise and a fall of the cardiac biomarker, preferably troponin, above the 99th percentile is the standard for the diagnosis. However, it's not enough, because you need one of those other criteria, such as symptoms of ischemia, ST elevation MI, new Q waves, a thrombus on coronary angiography, to call it a myocardial infarction. Otherwise, as it was stated before, we call it a myocardial injury and not a myocardial infarction. So this was the core of our guidelines. And then we discussed those multiple reasons that can lead to a higher troponin level, which is called myocardial injury rather than myocardial infarction. And I'm not going to go through the details in order to preserve time. And we wanted to keep our guideline easy. If we put a lot of variables, a lot of information, we know that they will not be used by our emergency room doctors and by our cardiologists. So we selected to adopt the 0 to 1 hour algorithm, because as Evangelo has mentioned, it is the most studied algorithm and it was validated in multiple studies, prospective and retrospective and meta-analysis. So we decided to use this algorithm where you measure troponin on arrival, and then depending on the value of troponin, you either can rule your patient out immediately if the value is less than A, and we will see what is A, and if the chest pain has been longer than 3 hours, or you measure the troponin at 1 hour, and then you make your decision. And as you know, for this algorithm, you can reach a rule in or a rule out decision in 1 hour in about 2/3 of the cases. And in the remaining 1/3 of the patient, you have to put them in this observational zone and decide what to do for them. So we recommended in our guidelines to use the 0 and 3 hour algorithm for those patients who are in the observational zone. So here, after you have done your troponin at time 0, at time 1 hour, if you decide that your patients need to be observed for more, you can do another troponin at 3 hours. And according to the algorithm, if you have a change that is more than 50% of the upper reference limit, if the initial troponin at time 0 was less than the 99th percentile, you rule the patient in. But if your initial troponin was more than the 99th percentile, then you need a relative change more or equal than 20% to rule this patient in at 3 hours. So, we felt that with this 2 recommendation, the universal definition of MI, the protocol 0 to 1 hour and 0 to 3 hours for those who are in the observational zone, we can reach a rapid and evidence-based decision. But those values are not easy to remember, A, B, C, D, and E. And those values are also assay specific. So it's easy perhaps to present them in a conference and discuss them in a conference, but they're not easy to remember and to implement in clinical practice, especially if you look at the assays. Those are the assays that were approved by the European guidelines as published in the paper of 2019. As you see, there are multiple guidelines and there are multiple A, B, C, D, and E values depending on the assay being used. Now, what's nice about the troponin T assay is that there is only one company, which is Roche, doing the troponin T. So when you do a troponin T in the United Arab Emirates and you get a value of 5, it is the same as the 5 we use in Lebanon or as the 5 that is being used in Germany. But if you do a troponin I assay and you get a value of 4, for example, this 4 may be 3, 1, or other value, depending on the troponin I assays that you are using. So one advantage of troponin T over troponin I is what we call standardization. We know exactly what every value of troponin T mean because there is only one assay doing the troponin T. The other problem between troponin T and troponin I is the gender-specific cutoff level. For example, if you look at this slide here for troponin T, and you compare here for the for the 99% percentile in men and women, we find that the difference between men and women is 6.6. And when you use 14, you are really abolishing this difference. So you use a single value of 14, a single 99th percentile of 14 for everyone. So you're not far from that of the men, and you're not far from that of the women. However, if you compare the cutoff, the 99th percentile for the troponin I assay, and here I chose the Abbott troponin I assay, which is perhaps the most commonly used troponin I, you see that the difference between men and women is huge, 18.6. And if you use only one value, 26, you are going to be very far away from the 99th percentile of women and from the 99th percentile of men. So if you are using a troponin I assay, you probably, for some assay, need to look at gender-specific cutoff. But if you are using the troponin T assay, you really don't have to look at the gender-specific cutoff. And in this studies, in several studies, and we summarize them here in a paper that we published this year, if you use gender-specific cutoff for troponin T, it does not matter. The diagnosis remains the same. However, if you use gender-specific troponin I, then you are going to reclassify a female patient from unstable angina to non-ST elevation MI, and you would reclassify male patient from non-ST elevation MI to unstable angina. So using gender-specific guideline, gender-specific cutoff is can be done and should be done for some tests with troponin I, but should not be done for troponin T. And we mentioned in our guidelines also the issue of renal failure. Many of our cardiologists were using a troponin I in renal failure patient. But in fact, you know, both of them perform very well in troponin T in patient with renal failure, whether you use troponin T or troponin I. And in fact, in this study published, troponin T was slightly better than troponin I. So it doesn't matter if your patient has renal failure or not. You should use either T or I, and you should specifically for those patients, more than the value you obtain in the beginning, you should look at the delta, at the change with time in the value of troponin, but you can use both troponin for those patients. Now, in order to make things easy, we decided to develop this high sensitivity cardiac troponin T algorithm, and it works for troponin T. Because as I said, there is only one troponin T. I mean, if we want to do an application for troponin I, then we have to do maybe 8 or 9, because there are several troponin I. So you can download this application from the Google Store and from the Apple Store. And when you look at it, this application is basically based on the Lebanese and on the European guidelines, where you measure troponin T at time 0, and then if your value is less than 5, and if the onset of chest pain was more than 3 hours, you roll out the patient immediately. If it's less than 12, and if the change after 1 hour is less than 3, you roll the patient out, or you can roll the patient in immediately, depending on the values. And if you are in this observational zone, then the application tells you to remeasure troponin T after 3 hours. So this is basically what you get. You get some question, is there ST segment elevation, yes or no? And then you have to enter the onset of chest pain prior to evaluation. Was that less than 1 hour, 1 to 3 hours, or more than 3 hours? And then the application send you to the 0 to 1 hour algorithm. So you measure your troponin T, you enter the value, and then you get those recommendations. For example, you can get myocardial infarction is ruled out based on the 0 1 hour algorithm, or you can get, you have a high likelihood of myocardial infarction because your troponin moved from 6 to 11. So this is a significant change. And here you can click on some links to see the definition of MI based on the universal definition. You can click on here to see the possible non-acute coronary syndrome causes for high sensitive troponin elevation. And you can also go to the ESC guidelines and read the ESC guidelines. So I am going to show you an example how it works. So in this case, this is the application. So is there ST elevation? And you answer no, there is no ST elevation. And then you get, you select the onset of chest pain prior to evaluation. So we selected 1 to 3 hours. Here you have to enter 6. This is the value of troponin at 1 hour, and you press next. The application tell you enter the troponin T at 1 hour. So the troponin T at 1 hour is 8. So we press next and we continue. And then we get this result. Myocardial infarction is ruled out based on the 0 to 1 hour algorithm. And if you want to do more, you can click here to see the ESC recommendation or to see the algorithm that we have used. So those are the ESC guidelines. So you can do more reading. And this is another example where you press on the application of troponin. So the patient does not have ST elevation MI. And then you enter your value. And here we entered 6, the same value as before. But the troponin increased to 11. So from 6 to 11, you are in the here a high likelihood for myocardial infarction. But this does not mean myocardial infarction. It tells you a high likelihood for myocardial infarction. So here you can click on MI and you see what are the definition of MI. So you need one of those other criteria to call it myocardial infarction. So this is an example of a female who was admitted to our hospital. And for the sake of time, Professor Abdelmajid, I think I'm going to move quickly. Her initial troponin was 18. We applied the 3-hour algorithm. It moved to 270. We took her to the cath lab where she had a very tight stenosis. We gave it nitro and it resolved, so it was coronary spasm. So this troponin is so sensitive that it can detect even a minor injury caused by coronary spasm. So we concluded our guidelines by 10 recommendations that we should use a high sensitivity troponin assay, that the value should be reported in nanogram per liter or picogram per milliliter. We should avoid those decimals. Deltas change over time is as important as the initial value. The protocol recommended is the 0 to 1 hour algorithm. It's preferred over the 0 to 3 hour algorithm, but we can use the 0 to 3 hour algorithm for early presenter if they present with chest pain onset less than 1 hour prior to presentation, or for patients who are in the observational zone. We emphasize that a troponin T by itself is not enough for the diagnosis of MI. You need the other criteria based on the universal definition. In renal failure, use either troponin T or troponin I, same cutoff, but the delta, the change here is very important. Don't combine using troponin T and troponin I. Some physicians in my hospital were asking for the two. No, stick with one of them. You start with troponin T, continue with troponin T. You start with troponin I, continue with troponin I. Don't combine all of them together. And finally, all those algorithms should be integrated with a detailed clinical assessment. So I stop here and I thank you for your attendance.
Thanks, Dr. Rabi. I think that's a great example of how to transform the knowledge into more of a point at the point of care of physicians and get it more practical to implement. Thanks all. I'll try to go over some of the questions quickly. I don't know, I was so optimistic at the start that I'm going to get time, but unfortunately I couldn't manage the time very well, but I hope we can go over many questions as possible. So try to go brief now on the answers. Okay. So one of the primary care physicians says, clinical ECG and troponin. He says clinical and ECG is enough. I don't need a troponin in primary care. I would just send to the hospital. Do we think there is a role for troponin in the primary care? Maybe Dr. Evangelos?
Yeah. So I think as long as in primary care, high sensitivity assay is not available, I agree. I don't think that there is a role. If a patient has a high suspicion for ACS, for non-ST segment ACS, because he did the EKG, he should refer to the hospital for serial measurement and observation. And that can be done quickly and the patient sent home. But in a private practice, in primary care, I wouldn't do that. And remember that even a patient with unstable angina means normal troponin, no troponin change into measurements. These patients also have the high likelihood to have obstructive coronary artery disease. So they are ruled out for MI, not for CAD. And that can only be further examined in a hospital setting.
So if you are, okay, let me take the question in another direction. If you are to recommend, say, a point of care in a primary setting or in a small center or clinic, what is your advice?
Yeah, if they have the chance to have an FDA labeled point of care test that is high sensitive, they can use it. At least they can see the patient with very low troponin concentrations and long time from the last pain episode. These patients, if they are low risk by clinical history, can be sent home. So I agree with that. And all others, depending on the possibility to observe, for monitoring, they should be at least admitted for short term. Yeah, but
what would be your advice to avoid overuse, say, in a primary care setting? Is there a monitoring mechanism or a way that, you know, because if I am to implement it, and this is one of the concerns I think our colleagues got, is if you implement it, it's going to be abused because of a high volume of patients there.
Yes, I have to be very, very, let's say, specific. My chest pain unit in Heidelberg, and we have about 330 chest pain units that follow our example. They do not only see patients with chest pain, they see cardiology emergencies. And for these patients, we measure troponin routinely in all. But, that is the but, we run these chest pain units with cardiologists that are present 24/7. So we are already specialized. We have more experience. We have more access to cath lab. We are not emergency physicians. So that is the difference. But I do not restrict the use of troponin to chest pain patients.
Okay, thanks. Dr. Leila, lab reasons for false positive and false negatives. Is there any lab, you know, for a clinician sitting in the emergency, is there anything that I have to know that, you know, we know the, and we talked about the clinical reasons, you know, the renal failure and all the different differentials, but is there a lab reasons that you would educate us about?
The false negatives, I think, are very, very important to remember. And remember when I talked about the hemolysis, the IV contamination, and so on, all these pre-analytical factors could really contribute. And your lab has to be aware of this to alert you guys to, you know, send another sample. False positives, Abdelmajid, used to be a problem before, especially with the contemporary assays, when you get interferences from fibrin threads and stuff like that. It is, or heterophil antibodies. We don't see this much, to be honest, with the high sensitivity assays. They are really very specific. So it's not a problem nowadays.
Great, thanks. Again, Dr. Evangelos, I think I saw a question that you already answered, but I think it's useful for a lot of people who are raising concerns about, you know, the value of this, of the high sensitivity troponin. So the question said there have been at least 2 studies showing no improvement in outcomes when using high sensitivity troponin.
Yeah. So that is a very important question. So you have to know that almost all observational trials, prospective or retrospective, were not appropriate for the message of safety. It means that, for example, the Rapid Army study is a prospective validation study, but that was run on high sensitive troponin I, and that was the Siemens Ultra. Nowadays, it's not regarded the high sensitivity assay any longer, but the physicians in these hospitals were blinded to high sensitive troponin T. They didn't know the result. So how can you manage a patient? How can you discharge a patient if you're blinded to the result? And in the other observational trials, the APACE registry, for example, they followed the protocol 0, 1, 2, 3, 6 hours. They did the best medical care. They were blinded to the protocols and the results. So to say that you can discharge the patient safely after 1 hour is, let's say, promising, because the test is so good. The troponin test allows risk certification, but it's not validated. And therefore, we needed randomized clinical trials. So we have that, 1 single trial for that. And we have some real-world evidence trials, a limited number, but all others are, I would say, not appropriate to test this question, particularly the high stakes Scottish trial. They ignored the newly diagnosed infarct. They didn't do anything, and they reported the new assays do not change anything because they did not respond to the result. That's the simple answer.
Thanks. Question for Dr. Aisha. Missed MI. I saw a nice slide from Evangelos showing, you know, different studies showing, you know, and looking at protocols with the different, you know, levels of missed MI, 0.3%, 0.5%, and then 1%, and then the meta-analysis. What is acceptable? I know the medical liability there comes in. And, you know, if you are to adopt a protocol, you know, I know the lowest is better, but then, you know, utilization of resources becomes an issue. Would you, you know, is there an advice that you would share with your colleagues?
So I would say the recent, so the recent literature, as we said, they also less than 2%. So if I'm going to go by literature, and Evangelist can add his input later on that, I would say sticking to less than 1%, looking at the 0.5%, 1.5, and 1%. I would prefer to be in that sort of kind of practice category, where whatever I practice should sort of ends with less than 1% if I can. However, as you know, when we investigate medical cases, what we want to demonstrate that we stuck to standard. So I'm practicing as a physician based on standard, and that I did really consider and put an effort to make sure if I'm sending patient home, I'm sending him safely. Now, in emergency medicine is always the risk when I send someone home. If I decide to consult cardiology to keep him, then we are in the safe zone from that perspective, but then it's not practical to keep everyone. So usually if I see 100 patients a day, we end up only referring 15% of that, so 15 patients from 100. But then there is about 85 patients that as emergency physician, I'll have to send home in my own. So then I would say, as long as we document, we document that we had put an effort to think about the process and to risk stratify the patient correctly. And based on what we are practicing, like let's say the 0-1 hour protocol, the heart pathway or whatever, then we should be in the safe side from medical legal. Now, from personal and every single physician perspective, none of us want to miss any MI. So our desired rate is 0 missing. However, we know every now and then we're going to miss one patient because for multiple reasons, it could be language barrier, could be history limitation, could be presenting super atypical as well. So regarding the rate, do you have any input, Evangelist?
Yeah, my input is that if we discuss about the missed rate with high sensitivity, then we should also discuss about the missed rate with conventional troponin, and that is in the range of 20%. So we miss far less than before. The acceptance rate is variable, and there's no consensus on that. And in an Apollo questionnaire with introduction of high sensitivity assays, the poll was acceptable rates for death between 0.5 and 2%. And so I think everything below.
I know it's a challenge. I'm just throwing it because, you know, in the ED, you're between, you know, resources, using your resources, and between, you know, safety of the patients and preventing a liability. So if I am to refer to a study, which study should I pick? You know, should I pick a protocol that is very, very safe, or should I pick a protocol that's practical? But
no, the best protocol will give you the best result, trading off safety and feasibility. And I think the guideline recommendations do not ask you to perform a coronary angiography in everybody. They give you a lot of freedom for selective invasive, but they also require for a suspected ACS to do tests, coronary angiography by a CT or a stress imaging test. So something has to be done, but not always, and not always in hospital. You can send the patient home and do the stress testing on an outpatient basis. So no need to hospitalize all low-risk patients.
Right. Dr. Rabi, you know, as a cardiologist, do you think still we have the entity of unstable angina with this high sensitivity troponin? We have this debate in the cardiology morning round sometimes, and some people think it's gone. Some people say, no, still there is an entity of unstable angina and we have to be cautious.
You're asking me?
That's a very good. That's a very good question, and you know, I really don't have an answer. You know, those troponins are so sensitive that we feel sometimes that there is no more unstable angina. But you know, sometimes you have patients who have like a change in the pattern of their chest pain with a troponin that remains, you know, below the 99th percentile and does not change significantly. So the only definition is unstable angina. But I think this diagnosis is becoming a rare diagnosis.
Right. Last question, I would, get it to Dr. Selman. I don't, I'm not expecting an answer, but just a thought, as to implementing a point of care in primary care setting here in Abu Dhabi. What are the challenges you're having? It's, do you see it easy, or do you think you're going to find a lot of difficulties?
Actually, we have point of care testing in remote clinics, which belongs to Saha. However, it is sometimes very challenging for the physician. We are afraid of the delay and whether they are going to miss the referrals to the hospital. So we really need the expert opinion. Is that shall we implement it in the primary care setting, especially in the remote clinics where the lab access or the access to the hospitals are far away or not?
Actually, that's a good point, So here, transfer and sending the patient to emergencies are not easy, they're 200-300 kilometers away. So an answer would be very useful, in terms of triaging those patients. So history, and we talk about the history or the clinical and the ECG, but, they want more tool to help risk stratifying. So if you're in a remote now, instead of being inside the city, I don't know, maybe Dr. Rabi, if you want to take that.
Yeah, I want to say something that, someone asked about the EKG. For the large part of patients with chest pain, the ECG is normal or non-diagnostic. So you cannot count on the EKG. And you need something else. Those, as Evangelo has mentioned, those point of care tests are not sensitive enough. And now we were discussing whether the acceptance rate is 0% or 1% or 5%. So if we want really to go to less than 1% of missing MIs, we have to use those high sensitive tests, and they're not complex to do. Any lab, I think, any lab can have a small machine that does a high sensitivity troponin T, and you get an answer within 1 hour. And in fact, the aim of this 0 to 1 hour algorithm is to decrease the congestion of those primary care center. So if they have it, they can reach a decision quickly. Who should go home? Who should be transferred to the emergency room?
So Dr. Evangelos, again, a point of care now not near a hospital where it's easy, to send the patient based on a clinical judgment. No, the patient is far away, remote. Would you use the point of care?
Yeah, if I have nothing else, I would use it because, as I mentioned, point of care, the non-sensitive assay point of care has a high specificity and rules in the patient. So if a patient in the primary care setting has an abnormal troponin, let's say a value above 40 or above 50, he rules in. He will have nothing different than an infarct. So this patient has to be sent to the chest pain center or to the emergency department accompanied with an ambulance, not by self-referral or taxi. So this is important. For the rule out, you cannot rule out. The lack of sensitivity prohibits that. So
yeah, you need the clinical.
You have to admit and do the serial tests, but at least you have a little help for the safe transport of the patient, for the timing of transport, and for the pre-test diagnosis.
Great. I think with, we're already beyond time. The questions and answers are very, exciting and interesting. We have a lot of questions still there, but I think just for the sake of time and respect of your, of the allocated time, I would like to come to the closure of this program. Please accept our thanks, from the Emirate Cardiac Society team, all of you, Dr. Rabi, Dr. Aisha, Dr. Leila, Dr. Salma, Dr. Evangelos, all of you. Thanks to our colleagues from Roche for their support of this program. And again, thanks to all our attendees. We had more than 450 attendees. Thanks all of you, and we'll see you inshallah in another programs. يعطيكم العافية.
Thank you very much.
Bye-bye.
Thank you.
Bye.
Nice
Bye.
evening.